It's about the same size as Cuero. So I grew up on ranches in big timber country. Oregon, has a couple of different areas. We have the green area that everybody thinks about. The place I grew up was over in the big mountains, big timber, right over the country of California. So there's a lot to identify with. I came with some things to say tonight. Let me be very clear. I'm here for you. And there is no question that you can't ask. There's a lot of problems with you. And I'd rather have a dialogue with you rather than me talking about whatever I'm interested in. This is billed as being interested in valvular heart disease. And I'll talk about that later this evening with some of the doctors. But that may not be the thing that's top of your mind. As a cardiologist and chief of division, I have about 30 guys that work for me that do lots of different things. So if you want to stop at some point or use the board here, so there's really something you want to start off with thinking about, please do stop. This is your time, not my time. And I really appreciate the chance to be here and get a chance to meet some. Compliment you on the museum. I do have a little postage stamp place over by a town called Utopia. I do have some Angus Gelfie. And have had the distinct pleasure of having my father-in-law buy a horse one time because it bucked me off. I had that horse for about 12 years, and I must admit, every time I went back, he wanted to know if I wanted to ride that darn horse with me. And I refused to. She was a great horse, and she was more horse than I was California. So, if I can, I'll start. Again,
I'm going to read something that I have on this piece of paper in case you do come across it.
Sure.
During your.
Please do.
All right, here. I got this through an MRI. You can probably understand it more than I can.
Okay. All right.
It was the back MRI that I had done, and I don't know, whoever reports all this stuff, reported that. My back doctor looked at it. He couldn't find anything wrong with all the other stuff and looking at the MRI, even though that guy said all this stuff was wrong. He said there's nothing that I can fix, He said, yeah, you've got, old age or something, as your body wears.
Well,
that one there, he couldn't find that either. He said it was probably the shadow. And whether or not I should be worried about that.
So, I don't, looking at this, I will tell you that if this was my interpretation for that particular area, I think you came to the right analogy. So what it says is that you have atherosclerotic disease in your aorta, which means you've got aging of your aorta. You earned that just the same way you did gray hairs. And does it mean much more from just this particular statement? I'm not talking about the back stuff, just the heart stuff. No, it's sort of like accumulating gray hairs and aging freckles and spots. You earned every bit of it, and no, it's probably not going to cause you a problem.
Okay, and my next question was whether or not you view these as being healthy. So lifespan or life.
Okay. So what he has is one of these life screening events. I'm a bit conflicted with these, and I'll tell you why. Because we recognize that people want to know how their body's doing. But I sit on a national committee that was asked pretty much that question. Is it helpful in patients who otherwise feel good, I suspect you do from what you told me, to go ahead and do these studies that look at your carotid arteries and all these other things? And the answer is probably not. Because most of the time what happens when you do those tests is you find, much like you did on this other scan, evidence of aging of the body. They're not causing problems, and they probably aren't more likely to cause problems than your friends or neighbors that are your own age. But because people get concerned about it, there often are other tests that get done that don't need to be done. And some of the other tests involve radiation and things that may be harmful. So as a society, we've gotten together and we've said that in general, those tests aren't exactly helpful. I think if you have problems, I think that there are reasons, and guys particularly, but some ladies who have a family history of swelling of the abdominal aorta, where that can cause a problem. You didn't have that. That screening for that's helpful. I think if you have leg problems or concerns, you've all seen the consumer advertising on TV about PAD and the nice picture of the lady who's concerned son is telling her she needs to get a look at. And the answer is if your legs cramp up when you walk, you probably need that look at. doing screening for that is reasonable to do. But most of the time, screening tests need to be done because people either have symptoms or your doctor hears or finds something that might cause a problem. But generally, it's sort of a routine screening. You know, as a medical community, we're sort of saying, no, that's not the right way to do it.
Or actually, does a heart doctor like yourself, do you do the screenings if somebody comes in? You know, what type of screenings?
So that's a great question. When would we do screening?
Whatever.
Yeah. So what we do know is that if you come in and talk to a doctor, and a doctor looks at you and examines you, often we'll do some basic tests. So an EKG is pretty much a screening exam that you get. And if there's a reason to do an additional test, we'll do that. But to do a shotgun bunch of tests, just to do the test before you know anything about a patient, that doesn't, more often than not, you have what we call false positives. It's abnormal. So the patient's fine, but the test is abnormal. Well, I'm not here to treat tests, I'm here to treat patients. So that's my philosophy about this. We won't get into the business side of all of that.
Just in case there was something in your presentation that covered this, you know.
Well, it doesn't. I'm going to talk more about valve problems, but some of it's similar in that the valve problems are a manifestation of aging. And so when we talk about that, it's the same kind of thing. Now, I'm going to try not to get too technical, although some of the slides I suspect are. But we are going to talk about valves and things. As I said, stop. Okay, just like this is great. I'd much rather answer your questions and speak to concerns that you have or something in your family. And this is a script. I can stand up here and only show this slide all night. That's okay with me. That's what you prefer. But they may be given the topic, and this is something that we're pretty darn excited about because of what we can do. So you got to listen to it. Let's see. We got a couple of minor things. So what I'm going to talk about is this aging process of the aorta. So when we're born, our aortic valves are about as thin as a piece of paper. And you can see through those pieces of paper. And it turns out that they move back and forth with about that much force. You can blow on a piece of paper and blow it across the room. So it doesn't take much to open heart valves, the aortic valve, when we're young. Now, some of us are born with abnormalities. About 2 out of 100 have something that happens as a child. Most of the time, the valve works pretty darn good for a long period of time. What we have found out is that as we age, as our arteries age, and we develop what's called atherosclerosis, everybody's heard of that, and that's really deposits of dead cells and calcium and cholesterol inside of vessels. And I didn't know this when I went to medical school, by the way. This is pretty recent stuff. It's only been about the last 10 years we sort of figured this part of it out. Our valves get sticky. They get sticky like doors. Right? If you have sticky hinge doors, it gets harder and harder to open, and if the hinges don't work very well, it squeaks and makes a sound. That's what happens here. The valve becomes, with all of these deposits on it, sticky. It's harder to open up. And so when you go to a doctor, and some of you may have had that. As I said, 2 out of 100 people have an abnormal valve at birth. And as we get older over time, you'll have people say, I hear an abnormal heart valve sound. And that valve sound is, it's harder to open, and so as the blood goes across it, it becomes turbulent. It's much like sitting beside a stream, right? If a stream is deep and flows smoothly, you don't hear it. But we all like to think of the brook, where it's lots of boulders, and you can hear the water as it's flowing around. That's what doctors are doing when they listen with that stethoscope with this, because of that turbulence, it actually makes sounds, it makes noise. And you can often figure out what's causing that noise by listening. In this case, as we get older, this happens pretty frequently.
When you say older, what range are you talking about?
Not like that.
That number changes. Once upon a time, I used to think that was 50. Now it's about 70 or 80. Actually, next year it may be a little older than 50. So that's a great question. It turns out, and it actually has changed, because I want to show you something that talks about 50 years ago, actually 40 years ago, we used to think older was 60, right? Well, we all know 60 is not old now. So now we are starting to talk about 80 as being sort of older in that group.
How worse is the aortic valve? The picture you just showed?
How big a rabbit is that?
Yeah.
Oh, let's see if I have something I can approximate with. So it's about that big.
Okay, so
Now, for the guys in the audience that have been out there, for many of you, I suspect you have an idea. It's about the size of, cows are a little bit bigger, but it's not too different from a cow, right?
Huh.
It's actually not very far off, actually. Deers are a little too small. But pig hearts actually are very comparable. So if you have ever seen a pig heart valve, not the size of a human valve. In fact, when we're testing these things, that's one of the things we use. We use sheep and pig hearts to test them, to prove that they work.
How many valves do we have? 8?
You have 4.
4?
Yeah. If you have 8, then we got a problem.
I thought there was one on each quadrant,
Yeah, so
an
that's-
inlet and an outlet, so I
Well,
figured 8.
Yeah. Well, we only have 4 chambers, so we have a 4-cylinder engine. Okay, so we were built economically, none of the 8 cylinders like in our pickups. So we have a valve that receives the blood coming back from the veins in the body. It's called the tricuspid valve. Thank you for making sure I covered that. We have a valve that then separates the pumping chamber on the right from the lungs, so that anything is happening in the lungs. That's called the pulmonary valve. And that frequently is abnormal in children. It's a very common place. And then once the blood goes out through the lungs, it comes back and it goes through what's called a mitral valve, and that's a receiving chamber. And it's called mitral because it looks like a miter sac. Catholic bishop's miter sac. We have to talk about Catholic Church and what they're doing. And then the aortic valve is actually the main actor here because it takes the pumping chamber on the left and pushes blood out to the rest of your body. So you can imagine, and I see some people here that I'm going to recall this, because I was only told about this, I never did this myself. But what I've been told is that when some of the older days with pickups and the smaller engines, if you stuck a potato on a tail light, that it wouldn't run. Is that, anybody here ever done that or heard about that? Yeah. So, and it works, doesn't it?
It sure does.
Yeah. See?
Unless your muscle bumper has a big hole in it.
So if you block the ability to exhaust things out of the engine quits. That makes pretty good sense. At some point you get backup pressure. In the car it's a little more fun. You get back at your friends, or not so many friends. The guy that took your girlfriend away. But in the heart valve, you can imagine if that valve that lets blood pump to the rest of your body gets too narrow, it not only becomes noisy, it actually keeps the blood from flowing, then you're going to have a problem, right? Because if the blood's not getting out, it's not getting to the brain, it's not getting to the kidneys, it's not getting other places, it begins to back up pressure into your lungs. And so when that happens, your lungs get stiff, and you notice that as shortness of breath. So aortic narrowing comes in a variety of flavors. Most of the time, you're not too high risk, and I'll come back to what I mean by that in a second. But there are some patients that are just too sick or too high risk to even be treated today. That's actually pretty common. So what does that mean? Well, what it means is that, I'm going to go through this, that basically about 7%, you asked about age, I said it's around 60. In this case, we're looking at 65. The numbers are a little different than 80. But about 7%. So, in this room, maybe not one of you, but perhaps one of your family members is probably going to have this kind of severe narrowing of the aortic valves. Has anybody had a family member that's had that? Okay. A couple. And that's what I would have predicted. And as you can imagine, it's pretty frequent. It does affect men more than women. We talk about a lot of things that happen as we get older, more often in women than men. This is one of the things where guys who are at risk. Okay? Abdominal aneurysms are another thing where guys are abdominally at risk of the age of 60. And so what are the symptoms that cause this? Well, there are lots of reasons you can have it. I mentioned you could be born with it. We call that a congenital abnormality. And I see a lot of adults that were born with funny things, pulmonary valves, etc. Anybody here know about rheumatic fever? Okay. So most of you probably are more familiar with it actually than my trainees, because medical students don't hear about it very much. But in the 40s, 50s, 60s, before we had treatment, there were a lot of people that had it. Some of you may have had acute rheumatic fever, but you can have narrowing of your valves, disease of your valves because of that. We don't see that as often, but because of who I treat, I actually see more than a lot of other people, because part of the valves I treat are narrower mitral valves as well. You can actually get infections or inflammations. So if you have joint diseases, as an example, a kind of chronic inflammation, you can actually make your valve disease. Most of the people, though, it's this age-related stuff. Okay? What is age-related stuff? Well, basically, here's who's at risk, right? If you're over the age of 65, getting older, if you are men, if you have high blood pressure, if you have smoked, if you have high cholesterol levels, then you're at risk. What did I just tell you about? You've seen this on TV, right? We talk about people that are at risk of having coronary artery problems, having heart attacks, people that have carotid artery narrows, risk of strokes, people that have peripheral vascular blockage. The same thing. It's the same disease. It affects the arteries in much the same way. You get this inflammation, irritation, and deposits. So how do you present with that? Well, what I'm going to show you in another slide is you really don't present till really late. So that's one of the problems. You can go a long time if they're pretty darn good, and then all of a sudden you start having a problem. What are those problems? If you start getting chest pressure, we talk about angina. Most commonly we think about blocked arteries, right? And that's not being able to supply enough blood. But if your heart has to work extra hard, then it may, even if you have normal arteries, not get enough oxygen. Right? So if the cylinders in the car engine aren't working right, even if you got enough gas in the tank, it's still not going to work well. Okay, you got enough gas in the tank and you block up the tailpipe, it's still not going to work well. Everybody sort of knows angina is a squeezing. Angina is a misnomer. It's really a pressure sensation which you get. And a lot of people get short of breath with that. This can be severe enough people can actually pass out. So I worry in older folks who, for no other reason, pass out, particularly if they do it with exertion or after exertion. You may get just short of breath and tired. And so one of the common presentations is, you're 68 or 78 or 88, am I just getting tired because I'm older? Well, a lot of times what I find out is when people come to see me, they've been told they're just tired because they're getting older, but all of a sudden you listen to them and you find out the heart's getting older. It's not them. If you fix the heart, then these folks are going to do better. Okay? You may get dizzy, or you may have a regular heartbeat. So all of those things, that's pretty, not terribly uncommon. I'm just giving you a whole list of things that, gee, I don't want everybody to stand up and say, I had that. If you think about it, it's not very specific. I mean, when I ask my patients, have you had any of these things? These are pretty common. Because you had one doesn't mean that that's what's going on. But it means you want to think about it. So the things you want to do is you want to listen. And it's amazing how often we don't do that well. Okay? That's one of the things in medical school, is we now have all these fancy tests I'm going to show you in just a second, and we don't listen to our patients, which is why I told you that I listen to my patient before I decide on a lot of these tests. I listen to what they tell me about symptoms, and I listen to their heart and their body in terms of what it tells me as well. It takes both of those. And there's some specific things that doctors listen for, and some specific findings. But basically, this is a diagnosis that you can make on physical exam without fancy tests. It's one of the easiest to make, one of the classic tests.
What do you mean by murmur, the heart?
Okay, great. I love to do this part of it, by the way, because I do it for my medical students. And that is, when you listen to have everybody heard that your heart goes low and up? Right? So your heart goes up, 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 up. When you have a murmur, instead of having just those sounds, and those are the valves opening and closing, what you actually have is the sound of blood that is disturbed as it flows through the heart. Because the reason you only hear love and dub is because everything's moving well, it's flowing normally. But if you hear love, 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 that's a murmur. And in fact, this kind of sound makes exactly that kind of harsh murmur. We talk about harsh, and it goes up and down, so we call it crescendo, decrescendo, fancy.
Is that turbulence to the valve that's causing it?
Exactly right. It's turbulence through the valve. And you can, it's the same thing that you have if you step on a garden hose, right? Or you narrow a garden hose down. You make the sound. You can hear the water flow through a garden hose. It's the same thing in the body. I told you, I'm going to learn to get educated well. all I needed to know, I learned, as a kid playing with ball. So it's exactly right. So it's the sound of that blood being turbulent as it flows through. So doctors do fancy things for this. Mostly we listen to it. You see about a quarter of the time you can pick it up by that. The fancy tests, unfortunately, that we default to are doing the tests you talked about, doing echocardiograms or heart catheterization, those kinds of things. EKG is not so good, but it's pretty good for that. But most of the time, we can figure this out pretty quickly. And so in our clinic, as an example, we do things a little differently. A lot of times you go see a doctor and you get their opinion. At the Health Science Center, I have a great luxury because I have not only myself, but I have the ability to pull the right people together all at one time. So people that have heart murmurs that folks are concerned about, I actually have not only myself, but I have a doctor that's a specialist in these echo images called an echocardiographer. They're with me. And I actually have a CT surgeon who's there with me. And we often have our pulmonary doctors and our neurology doctors. So we have just a different approach to how we do things today. And so it's no longer a one doctor kind of a thing. We see folks often in a single day. The tests are done in a single day. And so rather than having to make multiple trips back and forth about what's going on, we have a process with multiple disciplines where you get an answer at the end of the day. That's all we want. I mean, we want to go to the big box stores and you know, if you go to Lowe's, you don't want to have to go to 5 different stores to get what you want. You want to go to Lowe's, get it all. You want to go to Walmart, you want to go to wherever, and get all of that at one time. You just want to go back. You want to know. And so we figured that out. It took us about 20 years, but we figured it out. So we have numbers that tell us how severe it is, and we grade it just like everybody else does. You can tell how well you're doing with that. What I wanted to point out is this, because this graph here was done, and we haven't repeated that. This is a study that was done in Boston back in the 1950s and 60s. And it's not been done different because this is a problem which is a mechanical problem. It is a physical problem, and there's no medicine that makes it better, no medicine that helps it. You got to fix it. You know, if your muffler's got a hole in it, you might be able to duct tape it, but eventually you got to put a new muffler on. In this case, you have to get a new valve. So you can see that it goes for a long time before you have a problem, but once you have a problem, if you have chest pressure, if you pass out, or if your heart backs up and you're short of breath, those 3 things, you have a really poor outlook. It says you're not going to do well once you start having those things. You don't have a lot of time to think about it. In fact, if you look at this, and you ask the question, if you have this aortic stenosis and you're not able to have an operation, what's your survival compared to cancers? That's a pretty good comparison. We all are scared of cancers. We all say, if I get a cancer, I need to do something about it. And you can read the numbers down there as well as I can. If you have a breast cancer, you're much more likely to survive than if you have this. Lung cancers actually do about the same. So it's about equivalent to a lung cancer, except that we can treat this much better than we do with cancer. Because this is something that gets treated pretty simply, with a simple, straightforward approach. Our surgical colleagues have been doing this for a long period of time, and you would think that if you had this, it's okay, it's a pretty straightforward idea. So you've got chest pain, but you can't breathe, you pass out. You know, that's pretty clear. And you can do a test to define it. That's pretty clear. Everybody ought to get it fixed, right? Here are the numbers in Europe and the United States. And about 40% of the time, 4 out of 10 patients never ever get it fixed. They're never sent forward. They're never asked to get it fixed. Now, there's some of it, folks don't know about it. Some of it is, you know, that you're older, and people say, well, you're 78 and you're just too old. And then something can't be done. But those are the numbers across from LA to London to Belgium to New York. So it's something, and part of the reason we're talking about this is because you're going to have family, you're going to have friends, you're going to have somebody. Then you can know that this can be fixed. I think most of you are familiar with something called a stent. A stent was invented in San Antonio. I had the good pleasure of interacting with people who did that a while back. And what was said was, if I can make a tube that I can expand in an artery, for a disease that is atherosclerosis, why can't I make a tube that I can stick in the heart? Some of us, they thought we were crazy when we started talking about that. And we were. However, the answer is, most of the time, if you can ask the question, you can find a way to do it. Could we put a man on the moon? Well, it took a lot of money, a lot of effort. So what's happened is the same heart valve that the surgeon would implant, and the surgeons do a great job. I have an immense respect for my colleagues in surgery, and when we look at patients, we do it with the idea of what's the best for our patients. And if they do a sternotomy, and they replace the valve, they actually use exactly the same valve tissue. Now this is bovine, okay? It comes from cow heart, cow influence. And what they do is they actually have a ring that they sew in. As an interventional cardiologist, I don't have the luxury, and I don't want to have the luxury actually opening a chest and stopping the heart and sewing a ring in. What I want to do is something in which I can move tubes from outside the body, take this and move it inside the body. Well, that's sort of revolutionary. I must admit, I don't get many people coming to see me who say, can you cut me open and put a valve in and not do this thing to the leg down here? Or would you just do that? Okay. There are a lot of patients who come to me saying, I don't want to be cut open, that really would do that. So don't misinterpret what I'm saying. But there are patients who the right way to treat them is by doing something like this. So I'm going to show you if my computer works. It's a little slow in animation, and then I'll show you that this actually does work. You know, when you're thinking about new ideas for medicine, it's sort of like the old cocktail napkin that we saw for Southwest Airlines. You guys remember seeing that? You do that in medicine too. You have a cocktail napkin, that started with this, and then you do a cartoon or an animation, right? That's the second stage of any new device in medicine. So this is sort of this recreation of that open valve I showed you. And it turns out that with this, that what we can do is we now can actually go in the artery, in the leg, put a wire up. Wire's about, I don't know, the size of, it's a little bigger than a human hair, but not much bigger. And over that wire, we can go up. The first thing we do, and we do this sometimes even without doing the valve, is you can push this valve open. But all you do is sort of fracture it, and you make it so it moves a little better. It's like putting WD-40 on the hinges. You know, you do that, and the hinges are going to work for a while. They're still going to rust up again. Okay? So this balloon procedure works for a while. But after we do that, what we found out how to do is to take this valve, like I just showed you, squeeze it down on a balloon so it's smaller, put it through the aorta, the area that you have done down in here, and then across the valve, and then by making the heart beat really, really fast, we can actually expand that valve right in the place where the old one was. So the idea is you don't have to have the old valve cut out, you don't have to have surgery. And so what you can do is actually take this, push the old valve out of the way, and put in a brand new valve.
What happens to the old valve?
Push it out of the way.
No, does it break up? Does it?
No. It basically is no longer necessary, so it literally, you push it out of the way. Like, you're arriving at the fact that does that work in everybody, and what if the valve has different characteristics, and will it really push out of the way? All things we thought about, and the answer is, most of the time, it actually does just that. So over the last 10 years, we spent an inordinate amount of time looking at that, and there's a bunch of studies that have looked at it in patients who are too sick to have anything done, patients who could have surgery, and you can actually do this through the apex down here in the heart if the arteries are too small. Or even now, we're starting to pioneer a way of making a really minimal incision up right here in the chest, but it's beating hard. So the problems with surgery are in part related to stopping and starting the heart and being on a bypass machine. Those are, the good Lord didn't design us to have a hard stop and be on machines. So let me just take you through what happens. So this is that balloon procedure I told you where we expand the valve. You get an idea of what happens. We open it up right there. And the balloon is the size of what the valve really should be. And that's a pretty true size, by the way, from the back of the screen. If you walk up there, that's about the size of your heart. And then the next thing we do is we have a team. Now to do this is not everybody out there doing this. This is a team sport. We have 20 people in our room. Okay. 2 heart surgeons, 2 interventional cardiologists, an anesthesiologist, an echo guy, 2 surgical techs. I've got the pump techs. We've got all of our people. But what we're doing here is we're going to do just what I showed you. Here's this valve coming up, and it's going to come on down around here. And if it doesn't, it never catches up with itself. What we're going to do is we're going to do the same thing we did with the balloon procedure. It looks like it stopped, sorry. We're going to put it across here. I think we've got one more picture. There we go. So here is this valve right there. Watch it, watch it. Okay, new valve. So we measured the pressure difference in the heart, and it's usually 40 or 50 millimeters of mercury. So it's about 3 times the amount of pressure in your tires in your car. That's what your heart's beating against. You think about inflating tires in your car. The heart's having to generate 3 times as much pressure as it takes to fill your tires. And we go to this, in which there is essentially 10 millimeters. So the heart just sort of, all of a sudden, is relieved of all of that. And
Is that the total pressure clear across the heart from the?
so the pressure here at the end of when it's beating off, and it's 200 millimeters of mercury.
Okay.
And up here, when you have severe narrowing, it may only be 120.
Just across one valve.
Cross that one valve.
Okay.
Yep. Yeah. So what we've done is, in a period of about 20 seconds, we have done what surgeons take a while to do differently. Now, we don't do it the same. Okay, I have to be very clear about that. But what we do is, in patients who are not those that are that good risk, if you think about it, who am I talking about? Well, if you're a good surgical candidate, you want to get good surgery. And that's where our surgery colleagues come into play. That's absolutely clear. Because for 9 out of 10 patients, that's what you ought to get, and that's what's delivered. But what happens here is that, what about if you have bad lungs or bad kidneys? What about if you have disease in the arteries of your leg or your brain? What can we do with this? Well, it turns out that even if you have small arteries, we can actually go in the very tip of the heart and go across and do the same thing. It doesn't have to just come from the leg. So that's coming from the tip of the heart, and it's not going to play. We'll go to the other one. The other one I mentioned is coming from the top of the heart. Same thing. Basically, you can do this pretty much any way you want. So what happens with that is, what we've seen is, I showed you the curves of people that couldn't have anything done. About half of those die within a year. About 2/3 die within 2 years if nothing's done. For people who can't even have surgery, we reduce that by 50%, which means I only have to treat 4 patients to save 1 life. That's pretty good. In patients who are just high risk, what we know is if they could have surgery or have this, some very important things happen. If you think about it, surgeons are pretty darn good guys and gals, and they can get you through most surgeries pretty well. The problem is if you're 78 or 88, or in one of our first patients, 92. I'll share not names, so they probably saw in the news. One of our first patients was a 92-year-old retired gentleman. And his complaints were he couldn't carry his sacks of feed to feed his alpacas around anymore. That was how he knew he was getting sick again. Right? Other than that, he could do pretty much everything he wanted. So, and he illustrates pretty much our average. He had this procedure done on Thursdays, which tends to be our day for a variety of social, technical reasons. So Thursday he had the procedure. He was sitting up in a chair that night. The next day was walking, and he went home on Saturday. Now, that's much quicker than most of our patients. Most of our patients actually are in 4 days, not 2 days. As opposed to being in the hospital for an average of 7 to 10 days, and then often needing to be in a nursing home for an extended period of time, not because of the valve, but because you have breathing problems or trouble getting up and ambulating, those kinds of things. So what we see is that in patients who could have either, that the differences in terms of the likelihood of getting up and walking around is significantly better with this kind of a procedure. That makes sense. We don't do as much. It's less traumatic. Yeah?
You do this to all 4 valves that you're talking about, or only this one?
So right now, in the U.S., we can only do it to well, actually we can do it to 2 valves. We can do it to this valve and the pulmonary valve. Turns out that the technical parts of doing it to the mitral valve in terms of replacing the valve is a little more difficult. We can actually put this valve in the tricuspid valve if we need to, but that's not very common. The mitral valve is a bigger challenge than one on the top. How it's arranged is quite different. But I think we're probably only 4 or 5 years away from that. Now it turns out that if you've already had another valve in, a tissue valve that the surgeons put in the past, and that's beginning to degenerate, that's a common problem for us. Because we do that in your 50s and 60s, and now you're 70s or 80s, and now you need another valve, right? What we can do is we can actually do this inside of the other valve and not have a second surgery. So that's really, because if you have, your first surgery is sort of okay, your second surgery is really bad, right? The risks go up, you've got adhesions, just hard on people to do that. So some of the advantages of doing this as a second procedure is pretty simple. So these are just an example of some of the things we're doing. I'm going to advance very quickly through something just to show you what I think is one of the most fun things we do. And that is we actually have a little clothesline clip. So you asked about the mitral valve, and there's narrowing and there's leakage. leakage actually is the mitral valve, the valve between the top left and the bottom left, is one of the more severe and frequent problems that we have. And so we learned from a surgeon, Dr. Alfieri in Italy, who serendipitously described the fact that he had a leaky heart valve in a young lady, and he didn't want to replace the valve. And all he did was he took some suture, and he shows up here. So Antonio Alfieri put 2 little sutures in the heart valve. And amazingly, this person got better. Their leakage, that was all it took to make the leakage well enough in this patient. Well, you know, cardiologists say anything a surgeon can do, we can figure out a way to do from outside. Because that's just how we are. And it turns out that this clip, designed by a good friend of mine from California, does sort of the same thing. It takes a little more to do that than the surgeons do, because we have to play with lots of tubes and catheters and stuff, but we can reproducibly go inside of the heart, across the top of the heart, and down across this valve and place the clip. And this is another animation. I told you what you have to do, which doesn't look again.
So are you doing the same things with your tubes that the surgeon is doing with the knife? I mean,
No, we're not exactly doing the same things.
but to accomplish the same.
But the end point, yeah. So the question is, at the end of that, do we end up with the same results, and do the patients feel as well? Because there's really 2 things. One is, do you get the same results in terms of reduction in the leakage, and more importantly, do the patients feel as well? And it turns out when we do this, and this goes through the vein, we do. So we've got 1 trial already completed. We randomized it. Our surgical colleagues again. So my heart valve surgeon on the aorta is Dr. Carpenter primarily, with Dr. Sacco as backup. For the mitral valve, it's Dr. Sacco with a backup of Dr. Carpenter. So we randomized patients between surgery and this. And we asked the question at 1 and 2 years, was the leakage reduction the same, and did the patients feel the same? It turns out the leakage reduction wasn't exactly the same at close, but the hearts got better. And the patients felt exactly the same. They felt just as well. In fact, part of the reason I put this in is I had a 48-year-old guy today, security guard, great guy, that we did this on because he couldn't have surgery because of some other problems. And I talked to him today. I said, "How are you doing?" He said, "I'm doing great." I said, "What are you doing? Are you still employed as a security guard?" He said, "Yes, and I ran down somebody yesterday and caught him." I said, "Well, that's a pretty good functional assessment. I wasn't in a treadmill like you." So what we do is we actually do this in the heart, but we don't do this by looking at it like this. I wish I could, but I have to use an echo machine. So I actually watch this moving inside the heart with an echo machine. And we go down across this valve where the leakage is, and we bring it down, and then we clip it. So think of a clothesline clip, a little stronger than that. It's got some little teeth on it. We actually have to capture the mitral valve while it's moving back and forth. It's a great sport. And then we can check it, make sure if we don't like it, we can move it. The nice thing about this is that clip, much like a clothesline clip, if it doesn't work right, our surgeons can come and say, "Steve, you didn't do your job well enough for this patient." And so what we're going to do is we're going to come back and we'll take it to surgery, and 9 out of 10 times they can still do a repair of the valve in terms of valve replacement, even if we tried this first. So it's nice because we have and this is the valve. This is what it looks like when the surgeon's looking at it on this echo. And this is from my friend John Erickson, who's in the lab with me. And this is that clip as we're going down through there. And then the next one is the clip is placed. So now we've got a clip right there across it in one of our cases. So we actually can really do this stuff. I mean, who would have thought we could have done this kind of stuff and made patients feel better? And again, this is one of those things where a day or 2 later, patients who couldn't get out of bed, couldn't walk across the room, are basically back to a very normal activity. That's how quickly the heart recovers from this. So that's an example of some of the fun we have and how we're using technology. It's not the end-all, be-all. It's only a few of the patients, but the team we've assembled and the kinds of things we do, the kind of support we've had from the community to do these things, because as you heard, Dolph and Janey were very kind to us to help endow the ability to think these things up, to do animal studies to prove that they work, and then to go ahead and do the human trials in order to show that they work and benefit people. As you would imagine, all of that, no one wants to pay for that. So you have to have the support for the nurses and the research techs. And, you know, Lord knows, for a while there, I was the biggest purchaser of pigs in the county for all of our studies. Certainly I paid for more chow than anybody else did because our chow for pigs, I wish, you guys would love to live on this. I don't think that in terms of the cost per day. So you asked the question about how people do, and here's the baseline in 12 months between those who got treated with the device, and here's the people that got treated with surgery. They felt the same. So whether you had an open surgical procedure or you had this minimally invasive percutaneous procedure, it felt as good. And that's what it's about. It's how can I help people feel as good as they can, and what's the best way to do it. And so for us, part of the reason I emphasize the fact that I use a group of people to help us make that decision is it shouldn't be what can I do, it shouldn't be what can the surgeon do, it should be what can we do that's best for that patient.
One thing you haven't touched on, but I heard, is during the open heart surgery, a lot of people have kidney failure after that. Now, shouldn't that play a part in not surgery, in this type of surgery?
Great point. And in fact, it is exactly part of what we factor into that. Because if you look at risks, kidneys and lungs become the two most important features of who's going to benefit from one or the other. The third feature in that, by the way, is something called frailty. And you can look at some people and they just don't look like whatever you do, that they're going to be back and robust. We've come up with ways, of course, because physicians like to quantitate things where we measure your grip strength and how far you walk, and we have a score for that. But kidney disease is one of the big reasons why we do these percutaneous procedures.
Why does open heart surgery cause kidney failure?
Great.
Do you know?
Well, I don't know that I know the answer. I'm going to give you some answers, but I don't know if they're all the right answers. So one of the things is kidneys are designed to have good flow going to them. And if you diminish the blood flow of a kidney, they don't like it. So just lowering blood pressure, removing flow from kidneys, punishes them. Some of the other part of it is that some of the medicines that we give as part of all of this also affect the ability of the kidneys to filter blood. So the kidneys are a very complex machine that have the highest metabolic demand. If you look at the amount of oxygen that's used across that. So anything that disturbs oxygen supply, low blood pressure, diminished flow, or increases demand, is going to alter that. So, and then the nephrotoxic stuff.
My brother-in-law had open heart surgery and he didn't have quality of life. His heart was probably better.
Yeah.
But then his kidneys failed and, he went downhill and 2 years later he was dead.
So, you've hit upon exactly one of the important points we talked about, is trying to make that decision in that patient, not about the surgery, can you get through the surgery, but what's going to happen to you after surgery and how are you most likely to benefit from it. And we haven't talked about some of the things that happen, people that have this kind of heart problems, valve problems, are more at risk of strokes. And, whether it's early or late, strokes are a part of that as well. So strokes, kidney problems are big issues.
One other question.
Yeah.
You always talk about babies having a hole in the heart and having surgery, but I had read before that all babies are born with a hole in the heart. Is that true or not?
That is true.
All
So
babies.
great question. So it turns out in the uterus, because our lungs aren't working, in order to get oxygenated blood to the body, we have to move blood from the vein across the top of the heart to the rest of the body. And so as we're developing in the uterus, we have what's called a patent foramen, which is a hole in the top of the heart that lets that blood flow through. And theoretically, as we come out of the womb, and as we start to take breaths, those two layers of the heart will close. But they don't happen in everybody. In fact, depending on how you look at it, as many as 1 in 4 people have a residual slight opening in that area. It's only about 2 out of 100 that actually have a real hole in the heart. But that's a common thing. Turns out, as you would imagine, I've got ways of closing those without having to have surgery as well. Those are not nearly as challenging. Yes, ma'am.
This is not talk about valvular disease, but my husband had open heart surgery, and the cardiologist did a stress test every year. He would have to eat a go fasting and then eat high-fat meal and then go back and have another test done. I don't know, is that called a stress test?
Well, the stress test is the exercise part, and then there's usually a nuclear, some people do a nuclear imaging test, which I
That
think
might
is
be
what
what it is, because it was to see how the fat was processed, I guess, through the arteries. He had blockages, he had 4 major blockages. But anyway, I've read somewhere that they aren't doing that anymore. What is your opinion? Because he hasn't had it now in 3 years, and he had no idea he had his blockages.
So, and I sort of talked about it at the beginning, and that we've changed our philosophy about when we do things. So in patients that have had arteries, that have disease that have had arteries reopened, it used to be that people would do it every 6 months or a year. Well, we found out it wasn't very good for figuring out when you're likely to have a problem, because the stress test only helps if you already have a significant narrow, a fixed narrow. If you don't have that, it's not going to tell you how you're going to do it. If you've had bypass, if the bypasses aren't working, if you've had stents, if the stents are having problems, doing an exercise test can't help. In the absence of symptoms, it turns out that most of the time, the treadmill test didn't help us. It didn't tell us anything other than talking to the patient and finding out whether they had symptoms. So instead of doing it every 6 months or every year, what we said is maybe every 2 years and 5 years is the right time to do that. So I suspect that you have a good doctor that's listening to that. So that's actually very good. Most of the time, you'll have symptoms before you have a problem. The problem with heart attacks, and I'll just enlarge on that a little bit, is that heart attacks don't happen when you have a fixed blockage. Everybody thinks it's because I have concrete in my arteries and it's really narrow and that's going to cause a heart attack. That's not what happens. You get buildup and you often have angina. That's what gives you chest tightness, chest pressure limitations. Heart attacks actually are like bad pimples. Right? We got a young lady in the audience. But you all remember back, pimples are what? They're dead cells and inflammation and irritation, and they erupt, they get bigger. That's what happens with atherosclerosis in your arteries. You start off with a pimple on the inside of your artery that expands, and it expands quickly, just like a pimple does overnight. I don't know about you, but in high school, my pimples all came on at the most stressful period of time, and always at the worst possible time, right? And they came up overnight, because you always got a bad thing. So blockages of arteries that cause heart attacks happen just that way. Most of them never happen in an area that you have a tight narrowing. They happen in an area that has a little bit of a narrowing, but that pimple inside of there gets bigger quickly, and then it breaks open, and that's what blocks the artery. And a treadmill test, the reason I'm going through all of that, I'm sorry, is a treadmill test can't tell you that that's an area that's a problem. That's why the medicines have been so helpful, because the medicines, not really Oxygen, but the medicines are what? Cholesterol-lowering medicines, blood pressure-lowering medicines are what keep those blockages from getting there. You have a question?
Using that balloon valve that you spoke in, sir, what about if you have arterial flutter? Any problem?
Oh, yes. You're talking my language, because we just finished one of those. You're talking the newest thing, actually, because we just started that yesterday. It turns out if you have atrial fibrillation or atrial flutter, the top part of the heart beats erratically, and there's a risk of stroke. And so you're on medicines for that. One of which is warfarin, perhaps, or there's some other new medicines, Pradaxa, about those on TV again. Because Lord knows doctors don't get to tell you about it before you heard about it all on TV. But one of the things that we found is, so I have electrical, I said I'm a plumber, and I am, but I've got electricians that work for me because we train for the whole house. And the electricians can do a couple of different things. One is they can actually go inside of the heart and do treatments to get that heart to go from the atrial fibrillation back into sinus. Now, we don't do that in a lot of folks for a lot of reasons. It turns out the latest and greatest of that, and I'll just digress for a second because we just did two yesterday, is there are patients who are too risky to put on this blood thinner. Okay. And in that case, what we can do is we can actually now go up through the heart, across the top part, like we did for this last thing. But instead of going through the valve, we go out into the very dog-eared part of the heart with a magnet. And then we come inside of the sac around the outside of the heart from down here, and we go up with another magnet and go from the outside. We put this down before it's filled. So what we can do, we have a magnet here and a magnet here. The magnets meet. And then we take a lasso. You know what I'm saying? And we actually go around that, around the outside of this dog ear. And we actually put the lasso and tighten it up. And the lasso includes a piece of suture. And so when we're done, we can actually completely ligate, close off that part of the heart. 95% of the strokes that happen are from that one part of the heart when it's fibrillated. And we just cinch it down. We have a little thing that remotely goes in, snub it up, and clip it, and come on out. So what we have is a way for the right patient, in order to diminish the risk of blood clots forming in the heart when they can't take the blood. And we were very excited because we just did our first 2 patients of this. Not many patients have been done. There's only about 70 centers in the entire United States doing it. So we're excited to be part of that group.
And what's that called?
That's called a lariat.
It seems like I'm hearing more about AFib than, I mean, is it just more common? I mean,
Well, I hate to get back to that how old you are question. So if you look at folks that are 70,
oh, well, never mind.
but it's a great question. Why are we hearing more about it? We're hearing more about it for 2 reasons. One of which is we're all living to be older. We're living to be healthy older. Right? I mean, if you think back to your parents, my parents, grandparents, you know, if you lived to be 60, you were doing pretty darn good. Well, shoot. You know, today we're all saying, I'm just 85. I'm just getting started. And if you look at atrial fibrillation over the age of 70, almost 1 in 4 people have it. So it is really common.
I am hearing more about it.
So
She knows somebody that told her.
So, and the problem with atrial fibrillation is the risk of blood clots and stroke really is significant. Now, you know, if you have kidney problems or high blood pressure or other things, we have a score. And so we have something called the CHAD score. So you may have heard about that. It's not like Florida where they have hanging CHADs. This is actually but it's sort of it's a characterization of what your risk of a stroke is. And if your CHAD's 4 or CHAD's 5, which is this